helpful to funny.
Thank you. You're welcome. Hi, everyone. Thank you for coming, and I know we have many more logged in online. My name is Jen Corbelli. I'm the Vice Chair for Education, and it's my privilege to introduce Dr. Aju Mathew. We were residents together. We don't look any older. Well, you don't, actually. Without further ado, Dr. Aju Mathew is an American Board Certified Medical Oncologist and Hematologist in Kochi. He is currently working at the MOSC Medical College and the Ernakulam Medical Center. He's also a consultant at the Trivandrum Institute for Palliative Services, WHO Center for Palliative Medicine. Previously, he was an attending at the NCI-designated Marquet Cancer Center at the University of Kentucky. He was also co-director of the Hematology Oncology Fellowship Training Program. After graduating in medicine from the Government Medical College Trivandrum in Kerala, he has attained further training, just so many accolades, it's amazing. Attained further training in Cambridge University in epidemiology in England, Karolinska Institute in molecular biology in Sweden, and University of Pittsburgh, where he did residency in internal medicine and fellowship in hematology and medical oncology. He has published in major high-impact journals in his field, and he has also received awards from the American Society of Clinical Oncology and the American Association of Cancer Research for his scholarly work. Dr. Mathew is an ethics committee member for the American Society of Clinical Oncology and a working group member for the European Society of Medical Oncology. He is a founder of Meeval Care, and he lives in the Kerala state in India, and his wife, also one of our former residency graduates, Dr. Aju Mathew, lives with his wife, Dr. Aju Mathew, an endocrinologist, and their two sons, ages 3 and 5. Thank you so much for coming so far and coming back home to share your wisdom and expertise with us.
Thank you, Jen. It does feel like home. Thank you, everyone, for coming. In the next 40 minutes or so, I'll just give you an introduction of what I'm doing in India for now. And 2009 is when I came to Pittsburgh. Well, 2008, October 29th, to be precise, for the first time, when I came for interview. And then started my residency in 2009. Relocated to Kerala, that is south of India, in 2019. So it's been about 6 years that I've been living in India now. So my disclosure, I'm going to talk about Meeval Care, which we have founded. The outline of the talk, I will discuss the challenges of cancer care in India, but not entirely restricted to the country. It is there everywhere, regardless of whether it's India or the US. I review the impact of financial challenges underpinning cancer care, and I will introduce 2 solutions to mitigate financial toxicity and improve the quality of cancer care, with a focus on something called PROMs, patient-reported outcome measures. So we all know that cancer outcomes are inferior in low and middle income countries for various reasons. And what are they? High out-of-pocket spending, poor health insurance coverage, low public health spending, and high incidence of advanced disease. A lot of our patients are diagnosed at stage 4 cancer. And there is substantial information gap and awareness. And all of this contributes to substantial financial toxicity. This may be a term that is not very familiar to a lot of us. We think about toxicity as it pertains to medication side effects. But cancer care impacts the financial situation of a household. It is a term that is described how much problems a household get because of the financial impact of cancer care. The healthcare cost is rising in India as we speak. New advancements in medicine are happening, but that is taking a toll on the financial well-being of the family. In fact, in 2021, we actually did a study. This was published in Lancet Oncology of 22 studies from India, and we found that nearly 50% of patients in India go through catastrophic health expenditure. That is, they actually end up poor as a result of the fact that they have cancer. So what happens? When you have financial toxicity, you have a lot of consequences. It impacts your family, decreases the expenditure on education. People are out of school sooner. They're into the labor market sooner. Premature entry of the younger members into labor sector, overtime work. it actually impacts cancer care quality as well. Poor quality of life, delay of therapy, loss of pay, adherence is gone. So in a way, cancer outcomes are impacted by financial toxicity because they can't pay for their treatment. They can't adhere to the therapy that is recommended. And financial toxicity actually impacts the cancer outcomes as well, because if they can't pay for therapy, they don't survive as well as somebody who can afford care. And this is the context where we actually discuss various ways to intervene to mitigate financial toxicity at various levels, at the patient level, at the provider level, at the community level, and at the policy level. Now I'm going to talk about just two parts where we are working on trying to intervene. And those are, number one, provide open avenue for communication. Often what happens is the doctor and the patient are in two silos. They can't communicate that easily and freely. So we are doing something to reduce that barrier. And the second is obtain reliable information. So my work actually started in 2017 when I went to the American Society of Clinical Oncology meeting. It was eye-opening. One of the top 4 research presented during the American Society conference in 2017 actually talked about a simple intervention. And that simple intervention was something called symptom monitoring. And what we found was having such a simple intervention of symptom monitoring caused survival benefit. Patients lived longer when compared to those who are not on symptom monitoring. That dramatic. And when you compare that with the impact of some of the fancy new drugs called immunotherapy and targeted therapy that we use, it actually mirrors the impact of fancy new drugs. These are immunotherapy impacts, and if you can go back to the previous graph, quite similar result. Just monitoring symptoms actually improve outcomes. And this is a study that I was just talking about, where patients were randomized to getting symptom monitoring versus just regular care. And the symptom monitoring group got emails sent to them asking them to rate their symptoms on a scale of 0 to 10 and how they feel. If they go over a threshold, an alert is issued to the nurse, and then an intervention is being given. So what happens when you have one group that has symptom monitoring and the other group that doesn't? Significant survival benefit, 5-month overall survival benefit. Some of the fancy drugs that we use now have 4-month and 2-month survival benefit and cost thousands of dollars. Longer treatment use, less emergency department visits, increased duration of chemotherapy, and patients feel better too. So this comes to the whole point of what sort of healthcare are we giving to our patients? Are we having a patient-centric healthcare, or are we having a provider-centric healthcare? A patient-centric healthcare will give patient the power to report how they feel versus providers assuming how they feel. So that is at the crux of patient assessment, patient reporting. If you look at the various types of clinical assessment that we do often in our practice, there is something called performance assessment. For example, treadmill test in cardiology. You perform, and then you can assess how well they're doing. The observer-reported assessment. For instance, the family member will say how often your loved one had a seizure. So that's somebody else reporting how their loved one feels. And the third one is clinician-reported outcomes, where the clinician actually assesses how a patient is doing. For example, in oncology, we do the CTC-AE assessments. I gave a patient X drug. What is the level of nausea that the patient had? Is it grade 1, grade 2, grade 3? That's called clinician assessment. And patient assessment, patient report, is essentially a patient reporting how they feel, how they function, how they live their lives, and how they survive. And some of the tools that patients use to make the assessment is called PROMs, or patient-reported outcome measures. And what is unique about PROMs is that it is measured by the patient and not interpreted by the clinician. So the patient directly logs in how they feel, and the clinician has no responsibility on what that means. So what do patients report in patient-reported outcome measures? They can track their symptom. How bad is their nausea? How bad is their diarrhea, constipation? How bad is their fatigue? And they can also engage with the clinicians that way. And why is patient-reported outcomes measures important? Because what can't be measured cannot be improved. A famous management professional, Peter Drucker, coined this phrase actually. So it is very important that we measure how patients do. But measurement should not be where it ends, because just knowing how a patient feels should not be where it stops. You have to track and you should respond. And that is where these studies were important. And for that, there were several types of tools used to measure outcomes. The Edmonton Symptom Assessment Score, the NCI-CTCAE, the PROM score, and this is an example of an Edmonton Symptom Assessment Score. In this, the patient actually just talks about how bad their nausea is, for example, on a scale of 0 to 10. 0 being no nausea at all, 10 being they are miserable. So they can report it on their own. And plotted against the x-axis, the time, you can get a sense of how patients are doing over time. This is another tool called the OncoPro. Again, patients are able to monitor, track how they're doing. This can be related to the physician or the nurse practitioner. This is another way. It's called the National Cancer Institute Pro NCI CTCAE, where you're asked in the last 7 days, what is the severity of your symptom? Dry mouth, was it none, mild, moderate, severe, very severe, and patients can report that. And what is important is, in the yesteryears, we used to have paper trail. People were given papers to fill. Can you fill this form and tell me how you feel? But technology has been a great disruptor, has been a great leveler. So we started thinking about using technology to help relocate patient to the center of our healthcare delivery. And that's where this concept comes of using the E-PROMs. So instead of actually measuring patient outcomes using paper tools when they come to see you in clinic, we can effectively use electronic patient-reported outcome measures, E-PROMs, and that is using technology to measure how patients feel in between clinic visits instead of at clinic visits. And the fun thing is you can send reminders to patient. Hey, can you fill this form? Can you let us know how you feel? And then based on certain threshold alerts can be sent to the clinicians. But there are certain challenges with using electronic patient-reported outcome measures. The E-PROM should be easy to use. Patients should be able to comprehend it. It should measure what is relevant to the patient. And the doctor, the team, the healthcare team should actually interpret, should actually use the outcome of what they report. And that's where there's always this digital divide, because a lot of our patients aren't using their phones, aren't using apps, aren't online. They don't have Wi-Fi connectivity. So there could always be a digital divide where the doctors have access to all the technology and the patients don't. And was there an incentive to entering the data? How can we train the personnel to respond to triggers? So let me just take you through a glimpse of the clinical trial experience. Using E-PROMs in a cluster randomized trial, investigators tested the benefit of using E-PROMs in thousands of patients, where digital tool was used to measure how patients feel. In this large cluster randomized trial of US-based community oncology practices, patients with metastatic cancers were given the freedom to use E-PROMs versus regular care. Symptoms were measured and thresholds were determined. Alerts were issued when the patients go over a threshold, and the nurse and the healthcare team gets the alert and they can intervene as necessary. And what did they find? At the end of the monitoring time, they found that patients who were using the E-PROMs had substantially improved physical function score, health-related quality of outcome score. So digital monitoring actually confers a lot of clinical benefit. The orange line is the E-PROM assessment and the blue line is the usual care. And essentially the graph shows that patients who were getting the E-PROM based assessment did so much better than the others in terms of how they feel, in terms of their health-related quality of life. This is relevant for certain diseases also. For instance, after lung cancer surgery, patients who've had thoracotomy, they were advised lobectomy, they were given the tool. And at the end of the day, what they found was those who were using the E-PROMs for after lung cancer surgery, they had far fewer symptom burden and fewer complications than usual care. So even after a lung cancer surgery, if you give patients access to electronic reporting of how they feel, they experience far fewer complications. What about after they complete their lung cancer therapy? just monitoring them regularly using electronic PROMs actually help us identify recurrences sooner. They live longer. Can you imagine, we're using all these fancy new drugs, but just a simple measure, simple intervention of electronic patient-reported outcome measures actually help patients live longer, help us diagnose recurrences sooner. That's quite dramatic. And these are various trials that have been conducted in the US and outside of the US. And all of that showed that symptom control is better, quality of life is better, you're able to reduce the hospitalizations, you're able to reduce the ER visits. And in a summary, what happens? If you use patient-reported outcome measures, you're able to detect and manage treatment toxicities and symptoms. You're able to detect and manage relapse and complications. You're able to give advanced disease symptom palliation. It triggers for rehabilitation. It triggers for improved symptom control, reduced disability. And you can tailor the clinical and supportive care as well. So you can do a lot of clinical decision making. You can provide for better patient and provider communication. And electronic PROMs, or patient-reported outcome measures, are not restricted to oncology. They are seen in all fields, especially cardiology, in heart failure services, rheumatology, in chronic management of rheumatoid arthritis, so in lung diseases, ILD. So if you just search on the literature, you'll see trials, studies that are in almost all areas of medicine where patients require closer monitoring, chronic diseases especially. So PROMs are seen in all diseases. So we've been thinking about a lot of PROMs. We've been experimenting with PROMs over several years, but this has never gone into clinical practice in real time. This is still confined to clinical trials. And that's when my team and we sat together and we figured out that there is actually a problem, and this is the problem. In India, and I believe it's the same here too, we do not have a proper system of patients able to report how they feel. Patient-reported symptoms are lacking and suboptimal at best. So we asked our patients, what are your problems? And this is some of the things that our patients said. They can't ask questions, failure to ask questions. They are hesitant to share their symptom because the doctor doesn't have time, because they don't pay attention to the symptoms. Sometimes patients can't even remember what symptoms they've been experiencing in the interim time that they have not seen the doctor. There is a lack of medication reconciliation. There is a lack of medication tools. I'll just give you an example. Some patients are on rabiprazole and pantoprazole, both PPI, prescribed by two different doctors. Patient is taking two drugs and they have no sense of what drugs they're taking. They would come to your clinic and they would say they're taking the red pill, the yellow pill, but they have no idea what they're taking. So there is a lack of proper medication tracking. A lot of financial concerns as well. So patients report a lot of these problems. So then we talked about what happens at the provider side. At the provider side, there is a lot of errors that are happening, a lot of medical errors, and that can cause toxicity, symptom-related, and even survival. Even patients die because of medical error. In fact, 5 lives are lost every minute, according to this report. And in the US, apparently, based on some research, controversial research, medication errors can be even called as one of the top leading cause of deaths. So we have a problem. At the patient side, patients are unable to report their symptoms. We have a problem at the provider side, where providers are finding it hard to reduce the risk for medical error, are struggling to get patient feedback. So now we have a problem. Now we got to identify the tool. And that tool is the electronic patient-reported outcome measures and an appropriate response system. So we have a problem, we have a tool, and we have a right environment. This was a news article in our local language, came up in the newspaper just 2 weeks ago. And this is a latest survey. Where I live, 93% of my citizens, my countrymen, use smartphones. They have access to WhatsApp, they have access to applications, mobile applications, exceptional penetration of WhatsApp and smartphone into the community. So we have an appropriate time, we live in an appropriate time to actually test out a tool, a solution. So what did we do? So like I said, we have a problem. A patient reporting of symptoms are lacking. We have a tool, that's the E-PROM system, and we have a solution. So we designed a mobile application. And that application, we've called it Meeval. It's a sparrow, and we called it Meeval because the sparrow is almost always, it's a ubiquitous, the bird. It's always in season. It's always hovering around you. So like Twitter, we wanted something fancy, a bird. So we went with Meeval. Meeval is the name of the sparrow in our local language. So this is what we did. We implemented this simple idea. We built something called Meeval. We built a platform where we let the patient be at the center of their care delivery, and we empowered them to actively participate in the healthcare journey. And we take the concept of E-PROM into the actual community, and we give them the power to have real-time symptom reporting. We have the option to intervene based on the severity, and we can connect to providers, to other doctors, and we can measure and track and intervene as needed. So this is how the interface looks. So if a patient logs into the Meeval app, they can select the symptom that they have. They have a vast plethora of symptoms that are being provided. For example, if they have pain, they can select the body part. They can record a symptom on a scale of 0 to 10. We kept it really simple. We didn't use any great validator tools, because a lot of the validation, a lot of the research we do just ends up being research. It doesn't really become patient-friendly. It doesn't become community-friendly. So we want to keep it as simple as possible. And it may not be able to, you may not be able to compare one patient's experience versus another, but at least the patient serves as their own control. So they report on a scale of 0 to 10 how severe it is and what time they felt, what day they felt. They can report as many times as possible. This is how the interface look for medication. They can actually enter what medications they are on. And just because I'm in UPMC, I had the oxycodone entered. I don't have oxycodone in India, thankfully. But I just, for some nostalgia, I had the oxycodone written. But anyway, this is how the interface looks for the patient side on the left side, for the clinician side on the right side, where we have details of their names, the stage of the disease, who the doctor is, what are the common symptoms that they report, how is the trajectory of their symptom assessment, and what medications that they are on. So how it works, this is how we've set up the platform. Patient symptom reporting on the left side, it goes into the mobile app, into the web clinic interface. We can plot out graphs, we get reports, we get alerts at our side of the clinic with our nurse practitioner, and we can actually provide the intervention directly to the patient as and when the alerts are triggered. So is there an impact to actually using the tool? This is one example from some time ago when we were actually designing and testing this tool. This is a patient who just got chemotherapy. As you can see, a lot of symptoms on the left side. Everything is hitting 10 out of 10. And we get an alert, we intervene, and immediately her symptoms are better in time for the next dose of chemotherapy where she is hitting 10 out of 10. So we are able to hit all those symptoms faster, make the patient feel better. So using E-PROMs, very simple intervention, we are able to recognize their issues. So this is one pilot study that we did and published in ASCO journal this past year. We recruited 95 patients with cancer. 60% of study participants downloaded the app. This is where we actually didn't force them. We just gave them tracks and said, hey, we have this tool. Would you like to use it? And it was very heartening to see that nearly 60% of the patients actually downloaded it and started using it. And when we looked at the app usage, out of the 60%, about 50% are actually tracking their symptoms. And very few patients are able to enter their medication data. So we are trying to build a system where they don't really have to enter the medication data. We don't have the sort of system where our practice setting is not insurance friendly. So if you order something, it will not automatically get into an electronic tool. We have to manually plug it in. So there's a lot of scope for errors. A patient can see me as a doctor, get some medicines. They can go see someone else, a primary care doctor. They can get medicines from there also. Both of us doctors would not know what the patient is taking. So there's a lot of scope for duplication and errors. Now, let me give you some examples, some cases, and how this is actually helpful in my practice. It helps in terms of disease response assessment. This is a patient, a young man, 30-year-old with lung cancer. This is his X-ray when he came to see us. His entire one side of his lung is completely packed with fluid pleural effusion, malignant pleural effusion, dense consolidation, and all of his symptoms are at very high levels. The blue line is his cough. It's at 10 out of 10 consistently. The classic thing that we do when we have a patient with lung cancer, we actually get their tissue for molecular testing. But unfortunately, in this gentleman, it was very hard to get the tissue, and the tissue that we send, the test comes back negative. So we are unable to get a sense of what molecular change this patient has, and the patient is suffering through the initial few weeks. We try out gefitinib empirically, assuming that since he's young, a non-smoker, he could have EGFR mutation, but that didn't help. We gave chemotherapy. Patient continues to have bad cough, and suddenly we decided to then use something called alectinib, which is an ALK inhibitor. And because the EGFR one didn't work, we don't have molecular study testing done at this point of time. We are having a hard time getting the tissue. We are having a hard time getting a test done. So we are just empirically testing our patients. So we gave this patient ALK inhibitor called alectinib. And in 3 days, the patient's lung X-ray looks improved. His symptoms have started dropping, and he's much better. So these X-rays are just 3 days apart. So one is packed with pleural effusion. 3 days later, his pleural effusion is getting better, his consolidation is better, and we now have this patient doing much better with his symptom reporting. Now I'm asking this question to all of you. This patient doesn't have symptom. This patient doesn't have a molecular test showing that he has ALK mutation, but he's clinically responded so beautifully to ALK inhibitor. Can we make a case in point that using this E-PROM measuring tool, that the patient has felt so much better that he does have ALK mutation? Anyway, later on we did manage to get some tissue tested, and he does have ALK mutation. So using E-PROM, very simple tool where patient is able to track how they feel, we are able to assess their disease response. Toxicity assessment. This is a patient who's on another drug, again coming back to ALK, called serotinib. This patient has a lot of GI side effects. She's on a moderate dose of the medicine. A lot of these yellow, the red and the blue lines are nausea, vomiting, and gastrointestinal side effects. At that point of time, middle of the graph, we actually reduced her dose of serotinib. And remarkably, her symptom levels, the GI side effects have improved. So now we have objective assessment of how a patient does when you actually reduce somebody's dose. And thankfully, her disease assessment was fine, but we can actually assess the toxicity using simple electronic patient-reported outcome measures. We can monitor for rare side effects. This is a gentleman with immunotherapy-related side effect. He developed Lermite syndrome, which is a demyelinating condition, a very extraordinarily rare condition, where a patient is actually experiencing significant Lermite's shock-like symptoms in his extremities. And I asked him to monitor how he feels when I try out various measures, steroids, IVIG, rituximab, and there is no way for me to actually objectively assess the trajectory of his symptoms other than just listening to how he feels. So finally, after all of this, the green line is his Lermite syndrome symptom slightly getting better. So at that point of time, I'm feeling comfortable. I'm able to reduce the dose of his steroids, make him slowly get him wean off. So I can monitor rare side effects in patients. I can monitor the chemotherapy side effects. This is a lady who we gave chemotherapy. At every 3-week interval, you get a spike of the symptom. When this patient comes back in time for the next chemotherapy, I don't have to actually have her narrate how she felt during the intervening 3 weeks. I can just go on my physician dashboard, look at what all symptoms she experienced and what level, and intervene based on how she feels. So there is very objective symptom assessment that can help me as her oncologist take care of her chemotherapy cycles. This is someone else with a drug called pertuzumab, which regularly causes diarrhea. Now she also reports diarrhea, but I can effectively measure how much of diarrhea she has and when these symptoms happen. So essentially, during this, I can get a sense that she's able to live reasonably well with this drug, so I don't have to wean her off the pertuzumab. I can continue it because she's not hitting very high levels of disconcerting symptoms. So it helps chemotherapy symptom assessment, and it also helps me in intensifying chemotherapy doses. A young lady with breast cancer, she came to me, we gave her standard dose in end of September, came for the next cycle. I saw that she was doing well. We said, let's optimize your care. We'll intensify your therapy because she's young. We need to give her the best chance for a cure. So I did increase the doses because dose intensification does help cure patients. And she's done well. So essentially, it helps with chemotherapy dose intensification. It helps with disease assessment, side effect monitoring, rare side effect tracking, chemotherapy dose monitoring, chemotherapy dose intensification, and a lot of conditions where we can effectively give good palliation as well. But it isn't as rosy as I just showed. What are the obstacles that we face? Now back to a problem statement. Patients, we felt, really needed this. We really felt patients needed this because they were saying that they cannot report their symptoms. They are unable to tell the doctor how they feel. They can't measure their symptoms. That's what we thought. But Steve Jobs gave us the answer to this big question. A lot of times people don't know what they want until you show it to them. So this is where we are finding it very hard. Because a lot of patients, because it's cheap, no cost attached, it's not a fancy new drug, they don't take this easy, they don't take this seriously. So now the next set of doing it is the Steve Jobs way. I should wear a turtleneck and come to my patients and say, hey, I have this super cool app that you got to use. So like what Steve Jobs did with the iPod, patients unfortunately don't realize what they really need. You just have to educate them. So there's a lot of scope for educating patients, showing them what this tool can actually help, how this can actually help change the quality of care. And the other part is the provider. We felt that the providers, the doctors, they would love to get patient feedback. I mean, intuitively, you would think that the doctors want to know how patients feel, right? And that is where, it comes back to the provider engagement too. And I'm taken back to the Peabody statement a long time ago. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. The secret of the care of the patient is in caring for the patient. So for the provider, remember, for the patient, you got to counsel them, you got to educate them on how important this is for their quality of care. For the provider, you just can't educate them enough. You really have to care for the patient, to be engaged, to be able to use this, to be involved with the care of your patients. And there are more obstacles. Attrition is a factor. Some patients use it and they just don't initially, but they don't get anything in return. So and nothing to measure, nothing to report. So there's attrition, poor retention, and very few people actually are able to enter their medications. So that's a challenge that we are facing. Quite low uptake on medication reconciliation. And if we can't use this as a research tool yet because this is not validated. But that was not the whole point. One of the reasons I did go back to India was not to do more research, but actually to do something that pertains to actual delivery of cancer care. I didn't want to just remain in research environment, but I want to be in the community. So sometimes, you may not have to use a validator tool because this isn't validated. And you cannot compare between patients because this isn't validated. So, but at the same time, it serves as its own patient comparison. Every patient remains their own control. And there could be a disruption in the clinical workflow for some doctors. It is very challenging to integrate into the electronic medical records, our tool at the moment, because it's all different sorts of electronic health record systems. And often, a lot of what we do with the E-PROM monitoring is actually just monotonous, boring stuff. Because these thresholds, these alerts, the important stuff that we use are the black swan moments. These are rare. Some of these, I saved a life because a patient actually hit a threshold on high level of fever, and I got the patient antibiotic in time, saved them from a sepsis. These are actually exceptional events, but so these are actually black swan moments. And for now, this is entirely bootstrapped. So no funding from anywhere. This is entirely bootstrapped. So what next? What are we going to do next? We are planning to release customized electronic PROMs. For instance, packages for chemotherapy, packages for certain surgery, packages for palliation. So we're going to have certain packages issued rather than have the entire platform released to patients. So we are now thinking about customizing the electronic PROMs for certain disease conditions. We have not tested symptom reminder or alert. That is a fun way to do it, but I just wanted to get there later, wanted to test how things would do if we give patients the power to enter their symptom whenever they report, whenever they feel like. But we do want to institute a tool into the Meeval app where we are able to send regular reminders, weekly reminders for patients to be able to input their symptoms. That we help would reduce the attrition. That would help us increase the usability as well. We do hope to incorporate some AI models into it. For instance, simple interventions like how patients feel in terms of the nausea. Can we actually integrate artificial intelligence to provide alert responses on its own? But for that, we require large amounts of data. But eventually, that's a goal that we do have in mind. And to scale up the model to, this is the minimum viable product that we develop in oncology. But we do have a plan to scale up this model to have encompass a lot of other chronic diseases, including heart failure, ILD, and diabetes and rheumatoid arthritis management as well. So this is one part I was talking about. Meeval Care helps improve avenue for open communication between the patient and the provider, and doing so, we hope will reduce the financial toxicity and improve quality of care. Another part, another segment that we are working on, which will also be plugged into the Meeval Care, is to provide reliable information. A lot of the times, patients don't know what they are facing, and this is not just a problem in India. A study done in America just hardly 10 years ago, where patients were asked what stage of disease they are in terms of lung cancer, and hardly 10% of patients or so were able to tell them that they have stage 4 disease and that it's incurable. So reliable communication is very important, because if they don't understand what they are facing, the care is disrupted at various levels. The financial challenges increase, and a lot of the times patients end up getting high value, highly costly care towards the end of life. Patients on ventilator, intubated, spending a lot of money during the last days of their life because they just don't know what they are dealing with. So for that, we are working on building a tool called I Hope. It's where we have this language, a vernacular. My language is Malayalam. We are building a Malayalam language web tool that can give all practical information on almost all FAQs for all cancers. So we are almost completed the process of building the English part. We are doing the Malayalam part, and hopefully, eventually, we can get to other languages as well. So this is a web tool that is available outside of the Meeval app, but we intend to plug that into the Meeval Care as well, called myihope.com. We do have our own YouTube channel that will help patients understand information in simple layman's language. That will also be plugged into the tools that we use. So to conclude, financial toxicity is something that impacts my practice substantially. It is close to my heart. A lot of our patients have bad outcomes because they can't afford cancer care. A lot of cancer care outcomes are bad because they just they can't afford it. And a lot of the cancer care actually cause patients to plunge into catastrophic health expenditure. And as physicians, it is our duty to find whatever tools we can to mitigate the impact of financial toxicity, to mitigate catastrophic health expenditure for our patients. And I propose that electronic PROMs, patient-reported outcome measures, helps improve quality of clinical practice, reduce hospitalizations and ER visits, and may even save lives for our patients. And that is what we have been trying to do with the Meeval tool. And a lot of these people are helping me build this, maintain this, and take this to the next level as we plan our venture, our endeavor forward in the place where we live. And this is Kerala. It's called God's own country. It is a top 10 destination for Lonely Planet National Geographic. I welcome all of you to visit us. Please just email me before you come, and I'm happy to host all of my UPMC family here. It's a great honor to be back here, and thank you for inviting me. Thank you to the UPMC Medicine Department and all of my friends, colleagues, teachers, and everybody here. Thank you for this opportunity. Yes.
Great presentation.
Thank you, Dr. Noble.
Really enjoyable. One question is whether you thought about incorporating measures of adherence to medications. We've been, with sickle cell, we've been very interested in monitoring adherence to hydroxyurea, which needs to be taken for many years. And I think you have the same issue with myeloproliferative neoplasms, for instance. And you could use this tool also to monitor adherence, I'm thinking, right? And I wonder if the patient could actually self-record themselves taking the medicines or reporting their symptoms, and their answer could be extracted and into a metric so that they don't actually have to physically input multiple symptoms.
Yeah. So this is our greatest challenge, medication part. Very few are able to report how they feel, report their medication use. So, but there are a lot of tools that are coming. Even ChatGPT has a Malayalam version where they just have to speak and then it gets inputted. So I think we do see a lot of progress in the coming years. But the first thing we wanted to crack was the symptom monitoring. And the next thing down the alley is actually medication tool. But for sickle cell patients, this would be a very good tool to monitor how they feel over time. And,
particularly if you can link it to an alert in the EHR, once the symptom reaches a certain level, it automatically triggers an alert and the nurse responds.
Is there anything in the US for sickle cell patients of this sort of electronic PROMs here?
No, I think it'd be great.
Yeah.
So thanks again for coming. I have two questions. And if you're running out of time, that's okay. The first question is, we do have a number of people who are interested in global health. And having trained at our program here as a medicine resident and as an oncology fellow, I was wondering if you had any insights, the types of things that you wish you would have been able to learn better while you were here, knowing that you were going to work somewhere that wasn't within the US. That's the first question. And the second question is, I'm just, we hear so much, right, like about there's great disparities between the care that you'll get in a resource-rich country versus a resource-poor country. And you are actually, it's one thing to do the research and see it, but you see that on a daily basis. And I was hoping you could just speak to what the experience is like, maybe on a more personal level, about why some of those disparities may occur.
Yeah, for us to answer your first question, as a trainee here, you do get exposed to evidence-based medicine in a greater way. But sometimes when it comes to actually a real-world practice in a country like India, sometimes you do have to take the extraordinary route of bypassing some of the evidence to giving real care to patients. So what I understood in practicing medicine in India is evidence-based medicine helps, but at the same time you should have a way to incorporate the social and the financial challenges into the evidence-based practice as well. For example, you give chemotherapy to a patient or immunotherapy for a patient. Here the dose of immunotherapy that we use, for example, for a drug called nivolumab would be 240 milligram every 2 weeks. My patients can't afford it, so I end up giving 40 milligram, which is as low the strength of the vial as it comes, giving it every month. So 240 milligram every 2 weeks here versus 40 milligram every month, and we get almost as good result as possible, as same. So practicing medicine in India, we are able to reverse innovate. So now there are a lot of trials happening in the US that is attempting to reduce the dose. So we are able to reverse innovate. Now the second question, how different it is practicing in India, how the challenges there. So as a physician practicing in India, it is more or less like a social atmosphere to a social worker's role as well. You just don't restrict your care delivery or your ability to be a doctor as somebody who prescribes medicines alone. Sometimes I have to fundraise to pay for my patients' care. Sometimes I have to visit patients. Sometimes I have to actually take patients from their home to the hospital physically or arrange that. A lot of the social setup is important too. So I am as equally a doctor, an educator, a teacher, and a social worker practicing in India. And it's very rewarding in that way because, without the social work part of it, things will fall down the cracks. Just being a doctor alone doesn't get you what you need in terms of care delivery in India. You just have to have wear that hat of social work also. If any of the residents would like to come visit Shadow or work with me, please, you're welcome. Just talk to your program director, management, and I'm sure they will facilitate this. Thank you. Thank you for the opportunity.